Hello everyone, this is Sharmia. In this video, we are going to see about what is meant by spondylitis. Spondylitis is used for the family of diseases that share the clinical features like uh, inflammations of the axial joints, asymmetric arthritis, and enthesitis, and by a bowel inflammation. It means spondylitis means inflammation of the joints, arthritis, a strong association with the human leukocyte antigen B24. It will cause arthritis, inflammation, eye inflammation, bowel inflammations, and the spondylitis family consists of the following disorders like ankylosing spondylitis, spondylitis associated with psoriasis or psoriatic arthritis, undifferentiated spondyloarthritis, reactive arthritis, spondylitis associated with Crohn's disease and ulcerative colitis, juvenile onset spondyloarthritis. The prevalence of the spondylitis in the Caucasian population is approximately 0.5 percentage to 2 percentage. Ankylosing spondylitis and these are the most frequent types of spondylitis are undifferentiated spondylitis and ankylosing spondylitis. Much less frequent in the reactive arthritis. The clinical features, first of all, muscular features, or the muscle sensory symptoms includes inflammatory back pain. Severe back pain is there will be a severe back pain, peripheral arthritis, arthritis, and dactylitis. Inflammatory back pain. Back pain is the most common cause and be present in mostly 70% of the patients. Onset before the age of the 40 years. Incidence onset improvement with if we do some exercise, the pain will improve. No improvement with rest. Peripheral arthritis. The peripheral arthritis spondylitis usually have an acute onset, predominantly involves the lower extremities, especially the knees and ankles. Arthritis is typically asymmetrical. It will not be symmetrical. It will include one of the arteries. It will not include both the arteries. Next, enthesitis. Enthesitis is the site of insertion of the ligaments, tendons, joint capsules to the bone. The disease which refers to the inflammation of the enthesis. They are usually associated with the swelling, severe pain, and tenderness. Dactylitis means it's also known as sausage toe or sausage finger. Dactylitis is not specific for spondylitis. It's also seen in diseases which are involved in tuberculosis, syphilis, sarcoidosis, and sickle cell diseases. Inflammatory eye disease includes conjunctivitis. The symptoms subside within a few weeks. Anterior uveitis. The initial attack is usually acute and unilateral. Patients will complain redness, pain, and photophobia. This is a healthy spine. This is ankylosing spondylitis. Ankylosing spondylitis is chronic inflammatory disease which includes the axial skeleton manifested by back pain and progressive stiffness of the spine. It affects young adults with peak age of onset between 20 to 30 years. Male to female prevalence will be 3 percentage in males in compared with females on percentage. Clinical features include back pain, buttock pain, limited spinal mobility, chest expansion, hip pain, shoulder pain, and peripheral arthritis. Next, TMJ involvement in the constitutional features may have fatigue and fever, acute anterior uveitis, atlantome, axial subluxation. It can lead to spinal cord compression, Cauda equina syndrome. It's a rare complications. Kauna equina syndrome means it's an inflammation in the brain. Pulmonary disease, the patients have restriction in chest expansion due to the costovertebral rigidity, apical pulmonary fibrosis in renal disease, analgesic abuse nephropathy, IgA nephropathy, it's an uncommon. Secondary amyloidosis is also can affect the kidneys. Classification criteria. The criteria consist of a subset of clinical parameters and subset of radiological parameters. Clinical parameters include low back pain and stiffness for more than 3 months that will improve with exercise, but it not relieved by rest. Limitations of the motion of the lumbar spine in both sagittal and frontal planes. Limitations of chest expansion related to normal values correlated for age and sex. Radiological parameters sacroiliitis grade greater than 22 bilaterally, sacroiliitis grade 3 to 4 unilaterally. A patient is regarded as having definite as if he or she fulfills at least one radiological parameter plus at least one clinical parameter. Algorithm for diagnosing algolizing spondylitis history, physical examination, reduced range of motions of the lower back, modified scope test with the patient standing erect, the position of the fifth lumbar spine as process is marked by pen. Additional marks are made 10 centimeter above and 5 centimeter below in the midline. The patient bends forward maximally and the distance between the upper and lower marks is measured. People with a normal spinal mobility have an increase in the measured distance of 5 centimeter. Occipital valve distance. Increasing occipital valve distance is associated with the loss of lumbar and cervical lordosis and increasing thoracic spinal kyphosis. Next, chest expansion. Chest expansion is measured at the level of the fourth intercostal space. The expansion is usually 5 centimeter or more. The expansion of less than 2.5 centimeter is abnormal. Sacroiliac joint tenderness. Patient with pain in the region of the sacroiliac joints may have tenderness elected by direct pressure over the sacroiliac joint. Laboratory test acute phase reactant CRP and TSR are elevated to detect the inflammation. HLA-B27 testing among caseous HLA-B27 is present in 90% of those with the ankylosing spondylitis. HLA-B27 is present in about 8% of this population. A major test and abnormal appearance of the sacroiliac joint on plain radiographs is a hallmark of long-standing ankylosing spondylitis. The changes are widening, erosion, sclerosis, or ankylosis of the uh, joints. MRI of the pelvis is the most sensitive and specific evaluation for sacroiliitis. Imaging of the spine, scarring of the vertebral bodies due to anterior and posterior spondylitis is an early sign of spinal involvement due to ankylosing spondylitis. It's an image. Late stages of ankylosing spondylitis are associated with burgeoning syndesmophytes, ankylosis of the fascist joints, calcifications of the anterior longitudinal ligament, and anterior atlantacial C1 to C2 subluxation. This is an image. Next one, treatment. Goals of therapy: symptomatic relief to reduce the symptoms such as pain and stiffness, restore function to return the patient to the best possible functional capacity, prevent joint damage, prevent spinal fusion or and complications, minimize extra spinal and extra articular manifestations. Next, physical therapy and exercise. Home based or supervised group and individual exercise program can help to maintain the function and relief of symptoms. And initially, evaluation and training by a physiotherapist should be a part of the therapeutic regimen. Next, pharmacological therapy. NSAID is non-steroidal anti-inflammatory drug. Unless contraindicated, NSAID should be the first line of treatment to reduce the inflammation and further symptomatic uh, alkalizing patients. Sulfasalazine prior to the discovery of anti-TNF therapies in alkalizing spondylitis, the only disease-modifying agent that had been demonstrated to be useful in alkalizing spondylitis. Next, tumor necrosis factor alpha antagonist. Example, etanercept, infliximab, adalimumab. Approximately 80% of the patients with ankylosing spondylitis respond to the treatment with one of these agents. Improvement noted in patient assessment of pain, a functional assessment, degree of inflammation as assessed by morning stiffness. Predictors of response. The following parameters are predictors of a good response to TNF antagonist: younger age, shorter disease duration, good functional ability, elevated ESR and CRP, presence of HLA B27. Methotrexate. Some studies have suggested that methotrexate may be effective in some patients with alkalizing spondylitis. Currently, a lack of evidence to support the use of methotrexate in the treatment of alkalizing spondylitis. Next, glucocorticoids. Systemic glucocorticoids are long-term basics for patients with alkalizing spondylitis is not recommended. Injections of a long-acting corticosteroid into the sacroiliac joints may be beneficial in patients with marked pain at the sacroiliac joints. Next is psoriatic arthritis. Psoriatic arthritis is an inflammatory arthritis associated with psoriasis. Psoriatic arthritis affects men and women equally. Classification criteria. Following criteria be used to classify the patient having psoriatic arthritis. The presence of musculoskeletal inflammation, inflammatory arthritis, enthesitis or back pain. Plus 3 points from the following. Skin psoriasis present means 2 points. Previously present by history means 1 point. A family history of psoriasis means 1 point. Nail lesions. Onycholysis pitting means 1 point. Dactylitis present or past documented by a rheumatologist means 1 point. Negative rheumatoid factor means 1 point. Just just articular bone formations and radiographs means 1 point. His clinical presentation. Patterns of arthritis, distal arthritis, characterized by involvement of the distal intraphalangeal joints, asymmetric oligoarthritis in which less than 5 small or large joints, symmetric polyarthritis similar to rheumatoid arthritis, arthritis mutilans, characterized by deforming and destructive arthritis, spondyloarthritis. This is the arthritis. Next, dactylitis enthesitis nail lesions include nail pits, oncholysis, nail bed hyperkeratosis, and splinter hemorrhages, ocular involvement, uveitis. These are the images. Next, radiographic changes. Typical radiological changes include lysis of the terminal phalanges, puffy periostitis, and newborn formation at the site of enthesitis, gross destruction of isolated joints. These are the images. Next, treatment of psoriatic arthritis. The approach to the treatment of psoriatic arthritis include therapy for both the skin and joint disease, non-steroidal anti-inflammatory drugs, methotrexate, only limited observational data showing efficacy in psoriatic arthritis. Next, leflunomide, promising results with leflunomide were noted in a uncontrolled trial. Leflunomide is also effective in controlling skin disease. TNF inhibitors. Clinical trials have proven the efficacy of TNF inhibition in psoriatic arthritis. Undifferentiated spondyloarthritis refers to patients who do not meet established criteria for ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and spondyloarthritis related to inflammatory bowel disorders. Major clinical feature is back pain. Most patients with undifferentiated spondylitis are young men. Positive for HLA-B27. A substantial proportions of patients will evolve into a more specifically classifiable subset such as ankylosing spondylitis or psoriatic arthritis. With a longer period of observation, a great proportions may progress to definite ankylosing spondylitis. So spondylitis, two types, axial, peripheral. For axial means NSAIDs. By NSAIDs, no response for 4 weeks means disease activity. TNF alpha inhibitors or interleukin 17 inhibitors can be given. Then responders assess every 6 months. Non-responders 3 to 6 months means class switch TNF alpha inhibitor. Next are interleukin 17 inhibitors. Are agents switch among TNF alpha inhibitors. Axial for biologic DMARDs means TNF alpha inhibitors or interleukin 17 inhibitors. Responses assess every 6 months. Non-responses for 3 to 6 months means class switch TNF alpha inhibitors, interleukin 17 inhibitor. Agents switch amongst TNF alpha inhibitors. Peripheral means sulfasalazine or biological DMARDs. Biological DMARDs means TNF alpha inhibitors or interleukin 17 inhibitors only. Responders assess every 6 months. Non-responsive means 3 to 6 months. Class switch TNF alpha inhibitors, interleukin 17 inhibitors. Agents switch amongst TNF alpha inhibitors. TNF alpha inhibitors or drugs means adalimumab, golimumab, infliximab, etanercept, pegol. Interleukin 17 inhibitor, secukinumab. First pharmacotherapy, non-steroidal anti-inflammatory drugs are the first line medications for ankylosing spondylitis. These medications include indomethacin, naproxen, ibuprofen, diclofenac, meloxicam. Another class of NSAID is called the cyclooxygenase enzyme 2 inhibitors may help prevent the gastrointestinal side effects that result from some common NSAIDs. One example of COX-2 inhibitor is Celifrex. This is modifying anti-rheumatoid drugs such as methotrexate and sulfasalazine have shown some efficacy in treating. That's some. In this video, what we have seen is what is meant by spondylitis, and we have seen what are the types of spondylitis, clinical presentation, diagnostic criteria for spondylitis. Next, treatment for spondylitis. What are the treatment? Non-pharmacological treatment, pharmacological treatment, goals of therapy, and we have seen all the clinical presentation for different types of arthritis. That's all. Thank you.